Bioethics Seminar for 2024. I'm Simon Walker. I'm one of the lecturers here. It's great to have with us. We're really delighted to have David Hood. David is a IT training and development advisor working for the University of Otago, but he tells me that has absolutely nothing to do with what he'll be speaking to us about. He is also nationally and internationally known for his work on social cohesion, and in particular the use of public data, and then further to that, data is being used in the analysis of vaccines and COVID-related issues. I'm sure David will be able to say a bit more about himself as he goes ahead, but just by way of sort of our structure for today, David will speak for about 25 to 30 minutes. After that, there'll be a time for open discussion. At that time, I will invite people to raise their hand, and I will moderate the discussion by making sure everyone gets a turn. Okay, so I'll just pass over to you, David. Thank you very much for coming to speak with us.
Great. Well, basically, I have had a really weird few years with insight into what has been going on. So there's a story here. I'm going to flag a number of things I think are broader issues that really need to start being thought about and discussed along the way, but I'm imagining people in this room and on Zoom will also have a number of thoughts that this might spark. So I'm not presenting a particular argument so much as providing all the background of everything I've seen in the course of this. And I'm actually kicking off in 1693 with the astronomer Edmund Halley, who was the first person to go, oh, we can calculate death rates by age. Because there was one town in Europe that actually recorded ages of death. So he pushed the boundaries of what was currently available data sources in order to be able to say something about the rates at which different ages were dying. That took a big leap in the 1700s with Richard Pearce and essentially kicked off the insurance industry with what's called the Northampton table, where you could put exact probabilities on normal rates of death at different ages. So people have been constructively using death rates by age for over 250 years for discussing mortality, things like that. And that's an important history of how people think about death to keep in mind in the next little bit. In fact, by the late 1800s, it was really well established, and the kind of mathematical principles like you have a reference population that you say, if things were the same as the reference population, this lets us compare different groups. So by the late 1890s, if you go and look at the Statistical Handbook of New Zealand, there's a rather nice worked example in there explaining to people how useful this is and what we can do with it. And that essentially is the modern form of age standardized mortality rates from the 1890s. Then we take a big jump to me and my involvement in this, which is for a couple of decades, I've been quite involved in advocacy around the availability of public data and the use of public data for an informed country. So my background is not medical, it's as a data person keen for the country to get a better understanding of data, and that's where I was coming from. And prior to COVID, I kind of had a profile on various topics of the day that I've been discussing. So things like the singular uselessness of the business confidence survey compared to any other country in the world. Things like analysing online influence campaigns and how the connections were between those. I've done some work on that as well. And then COVID happened. And initially, I was just like everyone else watching the deaths soar in European cities and locking down with everyone else. But what got me to start combining data from different sources, which is really my strength, was that after we had eliminated COVID for the first time, there were a number of countries where people were saying, why can't we do what New Zealand did? And the response from some politicians, in fact, some chief medical officers in those countries, was COVID behaves differently in New Zealand. And this got kind of subsumed into an offshore view that COVID was never really a threat to New Zealand, that it was, it couldn't establish itself. So the first COVID graph I made was really that New Zealand and the UK had been tracking one another in rising known cases up until we went into lockdown, and then a week later for a virus life cycle, and then we went down and the UK kept going up. So that was the start of me having anything at all to do with public information in COVID. But because I had an existing following of data experts and media and data journalists in this big group of people, it remained a topic for discussion. And there were a number of other times where misinformation was being proposed. And one of them was around testing. In fact, there were claims by people who refused to accept that COVID existed, that 97% of tests produced false positives, PCR tests, false positives. There are a couple of times where New Zealand acts as a clean room for the world in COVID discussions. And one of them is that in 2020, in the 102 days in the middle of 2020, when New Zealand had no COVID in the community, we did 500,000 PCR COVID tests, making sure, and none of them were positive. And when you only have negative tests, you don't have false positive tests. And it turns out, jumping to my monitoring influence campaign hats, that a lot of the production of COVID doesn't exist material is actually initially coming out of what I will broadly describe as naturopath sympathetic circles. People who do not accept that viruses exist, do not accept that you can test for viruses, and do not accept that you can treat viruses because they don't exist. So the tests can't be doing anything, and they are producing graphs and statements like this 97% false positive one. And this is really a thing to think about in terms of audiences and discussion of COVID, is you're hearing headline numbers and people are producing things, but they aren't spelling out what their assumptions are behind that kind of material. In terms of claims about excess death, there were some very well-meaning things where they made what I will describe as horribly bad decisions along the way. And the OECD is one of them. The OECD in mid-2020 set up a data source for essentially monitoring when and how much there were epidemic waves. And to include as many countries as possible, it's really just measuring deaths. And it's measuring deaths compared to the average number of deaths in 2015 to 2019 as a baseline. So it ignores population change and population aging, because for a lot of countries that data is not available. But it does mean, for example, that, and I realise that people in this room can't quite see the finer numbers, But it does mean that by third quarter 2022, New Zealand is averaging a consistent about 16% higher than the baseline. And this is actually the major source of claims of mass death. Claims that New Zealand's deaths are 16% higher than expected, or tens of thousands of deaths. Both of those work out to the same numbers. The thing is, it doesn't take into account population change or aging. Group activity. Could people be bold and put up their hands? I'm going to do an auction of sorts. Come on, play along, he said. And if you're on Zoom, play along in your head. Go on, be brave. We know that deaths compared to the average of 2015 to 2019 is 16% higher. The question is going to be, and I'm going to go up numbers, how much higher do you think the living number of old people, the population who actually die naturally, is in the same period? So if you put up your hands and just drop them when you get to a number, when I get to a number you're comfortable with, that it's lower, that it's the same, 0, no population change. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. The last hand just, 17, 18, the last hand just went down. But for people on Zoom, 19, 20, 21, 22, if you've still got your hand up on Zoom, you are at least correct to this point. If you were to keep it up, you would start to be wrong again. In the time that deaths increased 16%, the living number of people who died, who are of the population who died, increased 22%. In the quarter since then, it's increased basically another percentage point. It's now 23. So that is, and the OECD decided to call this data set excess deaths by week rather than change compared to baseline or something like that. And as I said, this well-intentioned source is the single greatest source of supposedly official information supporting claims of mass death. If you actually read the documentation on the source, it's even got a special note in it about how you should treat New Zealand as having a higher baseline, because in mid-2020 there are 18% more old people and things like that. But of course, nobody clicks on the link for show me all of the description about the data. So there is well-meaning stuff that has been grabbed and misused in this area. And when talking about it and when thinking about it, you have to start thinking about how do we get past the fact that supposedly institutions that are well-meaning, and they genuinely are well-meaning, have done things that are being interpreted in ways that the people who set it up didn't have in mind. And this is the single most effective bit of science communication I've ever made that has caused so many people to stop and go, oh. And in fact, this is one of the major, this graph is one of the major reasons that I get so many threats because I produce something like this. The graph in the very top right-hand corner is from Our World in Data, and it is using the OECD method of deaths compared to the average of 2015 to 2019. And I'm breaking that down into total deaths, the under 60 deaths, the 60 to 79, and the 80 plus, with the under 60 deaths being about 14% of the total. But then I'm showing the population. And then I'm showing what happens when you divide the deaths by the population to get the death rates for those ages. And giving people the steps that they can think it through themselves, what that means. has proven very effective at reaching people who have been frightened by things but haven't had it explained to them how things fit together. And then we have the worst headline in the pandemic for misinformation. This gets screenshotted in anti-vax circles so many times. The headline could just as easily have been New Zealand deaths return to normal after the biggest drop in 100 years. And in fact, if you read the article, it talks about how, there's not, huge unexpected numbers in that. Just jumping back to the previous graph, if you look at the bottom line, you see that huge dip in the year 2020. We did that. That's a reduction in the death rate beyond anything seen historically. And that reduction in the death rate came from wiping out lots of respiratory viruses that couldn't survive lockdown any more than COVID could. And we had water quarantine for longer than virus life cycles. So there's a reason for it. And this is another thing when talking to people, is being able to provide that added context that makes sense to people. I just happen to know an awful lot of added context in this area by now. And in fact, we had record low hospitalizations. And if you look at cause of death, there's record low respiratory cause of death and all of those kind of things in 2020. But it does mean, jumping back to this graph so that you can see that dip in 2020, and is that there are two main techniques that people creating misinformation use. One, they ignore historical trends. The second is they start counting from 2020. They portray it as the bottom of the biggest dip in mortality in New Zealand history is a normal year, and anything up from there is an abnormal situation that has conspiracy reasons attached to it. But part of the problem is that producing bad, wrong information is an extremely quick process. I've highlighted, blurred out, less than the total production of one anti-vaxxer over 2 weeks with graphs about New Zealand, one misinformation producer. More than an average of one graph a day, all looking different, so appearing to be different claims. Claiming that 2021 was...
That's okay.
Yeah, up to, I think on one of his graphs, there was up to 7,000% excess mortality in New Zealand. Once again, fudging what is excess and all of those kind of things. So, a broad point I want to make about being in situations with these claims is the importance of establishing they have to make sense with other things that we know. This is part of the whole ontological argument about how we know stuff. It has to be consistent. So claims about mass death in New Zealand have to be consistent with the death rates by age being lower than before COVID and things like that. And in fact, the ONS, the Office of National Statistics in the UK, is just making the formal decision to stop discussing excess deaths and start discussing excess mortality as death rates by age based and things like that, because there's been so much misinformation. And I would personally say that it is high time statistical authorities all around the world and medical authorities began talking in terms of death rates and historical trends rather than just saying there are more or less deaths than a time in the past. Because we absolutely know now that gets exploited by people misusing that, and it's much harder to exploit death rates. So the ONS is currently having, in fact, some of the same people who used to claim that COVID tests were producing 97% positive are now complaining that the ONS is finding old people to explain this increase in deaths over time, and things like that. But always thinking about context. I mean, not a technical definition, but my rule of thumb is vaccine safety is what happens to the deaths when you have vaccines and don't have COVID. Vaccine efficacy is what happens to deaths when you have COVID and don't have vaccines. And New Zealand debates consistently are on safety because as a country, we have no experience of the mass deaths they have been seeing in low vaccine countries that you can see on the left two panels of the graphs on the screen. That is Bulgaria and Serbia that are basically some of the lowest vaxxed countries in Europe. And age standardized mortality was in 2021 when everyone else was vaccinating and they weren't. It is up to 40% above normal trends for the whole year. So that's some stuff I wanted to tell you about initially. I've been producing a lot of this kind of material. I have been circulating it. People talk to me. Journalists ask me questions. I have wound up chatting methods with people doing COVID modelling, but it's all been a spare time. I don't have any funding. This is just me. I can't really call it a hobby activity. It's more something I feel I am being community useful for, and no one else is obviously doing it. So I wind up doing it. But to be frank, if you do this kind of thing publicly, you do get threats. And some of those are not to be taken lightly. But it does good as well. I also, because I'm good at data workflows, maintain a COVID information site that brings together all of the current public data for the current status of it. So Dunedin should be about to drop in COVID levels now that the students have settled back in and we're over that mini wave. But that's sort of the story that's brought me here. What we've got, in my opinion, is we've got a situation of both never before seen awareness and understanding of epidemics and how they play out and things like that, and also never before seen levels of misunderstanding. But those are actually quite small but vocal. I did joke the other day that New Zealand has never had more people aware of New Zealand demography internationally, whether right or wrong. There's so many people who now understand we're an aging country and a population size and things like that. But what I'm hoping for from this point on really is just discussion and throwing ideas around, because there is also a lot that should be formally researched. I'm not an academic. I'm not publishing in an academic manner. I am putting things out directly into the world and they are getting picked up. And to be honest, when I figured out COVID infection rates by occupation, by linking a few things together and worked out that teachers had the highest COVID infection rates, That got picked up by Radio NZ in an article, and that article got into the cabinet COVID briefings. So when I was reading released COVID material from the government, I was quite surprised to see my own name, what David Hood has calculated for something that I had done in my spare time, unpaid. But as I said, there's work here to be done.
Great, well, thanks. Let's all thank David together now. The Zoom audience can see you.
Yep.
Now, as I said, just raise your hand if you'd like to ask a question. And for those of you on Zoom as well, you may either you'll need to start your video and give me a wave, or put up your hand using the function there. And I'll try and get around everyone. Please keep your comments brief to start with, and and we'll leave space for responses as well. So let's start with Josie.
David, I know you probably don't want to repeat things that are false, but I think some of us just live in a different world than you and don't encounter much misinformation, thankfully, and I'm one of them. So just to be really explicit, is it the case, I think this is the case, but that some of the misinformation you're combating is people saying that COVID vaccines themselves have caused mass numbers of New Zealanders to die? That's right, is that not right? That's what's being said. Just
for the people on Zoom who might not have caught the question, I will formally state it. It is absolutely the case that there are multiple claims of high levels of death as a result of the vaccine. Claims, I'm not talking about 1 in a million genuine, very tragic cases. I'm talking about claims that range from 1 in 1,000 vaccine doses have killed someone to 1 in 5 in the sillier bits of the internet. That 20% of New Zealand's population has died as a result of the vaccine. But the standard claim is that while having a lower death rate, the natural increase in deaths, which is of the order of about 12,000 over the time period. The standard claim is that natural increase that you get with an aging population is the result of vaccines.
Thank you. Sorry to make you say it loud, but I think just
John.
Thanks, David. I'm John McMillan. I'm a professor in the Bioethics Centre. I was interested when you said earlier on about where this is coming from, why people are doing it, and you suggested about it. I just thought I might recount the experience I had sort of 7 or 8 years ago around fluoridation. So there were 3 judicial challenges to South Taranaki District Council's decision to adjust the level of fluoride in their drinking water. And one of the things that was sort of just really intrigued me about it was like High Court, Court of Appeal, Supreme Court, and it costs a lot of money to do this. And I was thinking, well, so I had some involvement in the first one and wrote an affidavit. And it was Jonathan Bennett, Broadbent Dentistry, who said that the people funding the legal challenges, it was an organisation called New Health Limited, and they are a lobby group for the alternative therapies industry and a registered charity. And I had just thought that it would be good if there's a little bit more investigative journalism around some of these entities with deep pockets who are registered charities.
Yeah, to some extent, we're in a slightly different age now, with New Zealand being what I will call the recipient of international misinformation. And you get a lot of things developed as ideas overseas and being spread in the US culture wars that flow in through sympathetic channels into here and don't quite make sense here. So for instance, to go back to the claims around false positives in testing, that's a potentially reassuring thing to people in a high COVID environment. I might not actually have COVID. It doesn't make sense in a no COVID environment where you're getting no positives, but it also doesn't make sense in a no COVID environment where you are fully genetically sequencing COVID cases in order to contact trace on the back of that, which is something that New Zealand was doing. It's another contextual point about the impossibility, but it is something else that was only really going on in New Zealand because we had low enough levels of COVID that we could contact trace and things like that. There's going to be a similar inside New Zealand, outside New Zealand issue when it comes to actually bridging the maths around death rates through the pandemic period, because most countries are now faced with the question of what do we consider a normal amount of deaths when we've had these giant spikes in deaths. New Zealand has the opposite problem of what should we treat as the baseline when we've had this massive drop. And in fact, that's a whole other issue, is we now know how low the death rate can go. And that raises ethical issues about what should we be trying to achieve.
I think we are able to unmute individual participants if they do want to speak. Do we use the participants button for that?
Participants is absolutely a way of using that.
So if you are online, you wanted to speak, did you want to speak, Janine? Well, let's unmute Janine. Should we need to find her? Under the participant list, I think.
Yeah. But I can start addressing the question in chat and possibly we can have some follow-up.
Yeah.
Is there a way to capture life years lost from COVID better than capturing life expectancy?
Here.
Sure.
I am unmuted.
Yep. Short answer, no, I don't think there is a better way than subtracting age of death from a higher level and then doing the maths off the back of that. It doesn't actually change much from counting up from 0 versus down from lives lost when you start comparing New Zealand to other international countries, though.
So, yeah, I'd like to tell you a backstory. I'm a palliative medicine doctor, and I was a pediatric palliative medicine doctor during H1N1, which got a lot of press as being the flu that killed children. Yeah. And because I was in the hospital with children at end of life, yes, indeed, it killed my children who were at end of life, but it didn't seem to kill any other children. And so the life years lost was, I would say, in children was very low. Now, COVID's a different animal, but I'm thinking that in the next pandemic that we need to try to capture life years lost by not just counting people who were nearing end of life and were extremely vulnerable and got a virus that killed them, but trying to differentiate that population from the general population. And I'm wondering if you think that's possible.
I think it's loosely possible at a population level. I've seen people make good efforts at that. I'm just going to reshare my screen because there are, in fact, 2 graphs I made on other occasions that I didn't include in this that have some relevance to this particular question. You said bringing. This is a graph of under 60-year-old mortality in Bulgaria versus New Zealand through the period where everyone in New Zealand averaged a dose of the vaccine. And people in Bulgaria under 60 were basically completely unvaccinated. And you can see what the normal range was up until COVID, and then you can see what happened in a high COVID country, a high COVID low vaccine country. So there is absolutely a bunch of years of life lost that you can just see compared to the normal loss of life in a relatively young age group. And something a little bit more speculative that I will put up is this is the COVID deaths in orange as a proportion of non-COVID deaths in the week. And then the lines are the past, pre-COVID years. So you can really see how 2020 was the year without winter in terms of respiratory diseases. But also, there was the initial COVID wave, and then in New Zealand, like other high vaccine countries, I think it'd be very interesting, and this is me actually getting back to the question that was asked. I think it would be very interesting to explore the idea that COVID is under enough control that it is an opportunistic disease preying upon weakened people in a high vaccine country. And so we've still got a reasonably low death rate in 2023, and COVID, despite having COVID and all the other pre-COVID diseases back, we are at a low level there. So there's some interesting things, I think, to be explored around that idea of how a disease that is under control is playing out versus in its acute phase, which I think we were seeing in that graph of young people in Bulgaria versus New Zealand. So that's just my thoughts off the top of the head on that one.
Thank you. Right, Mike, I think you had a question.
Thanks for a great talk, David, and it's lovely to have you here. I'm just thinking the work that you're doing is using exclusively, I think, openly available information. So data that's usually provided by governments, things like that, I suppose, healthcare systems. And the people who are doing all the misinforming are often using that similar data as well.
There is an almost weird fetishization of data as a concept without context of that data.
So I'm just wondering whether, well, I'd be interested to know what your thoughts are about whether we have enough openly available data, whether we need less of it, more of it, different types of data as well, and perhaps something to do with more contextual information around that data, or some other kinds of guardrails perhaps around
I think
how it's presented.
The amount of public data we have in New Zealand is extraordinarily good. For an Anglosphere country with the amount of public spending we have. I have joked on occasion that we have Scandinavian levels of quality on an Anglosphere budget. And yeah, stats in New Zealand do really well in that respect. I think where the misuse comes in is the ability to take a source and use it in isolation. And that will always happen, but I think it is better addressed with more mindful commentary and guidance about how things fit together. I mean, I'm not sure the last time I used the phrase death rates by age by itself, rather than saying for the past 250 years, death rates by age, just for adding some context to phrases. But that context isn't always relevant. So you know, it's understanding, not the data itself, is where I'd have to go. I would add, because it's kind of an illustration of that the reason New Zealand has the big increase in deaths due to the big increase in old people, which anti-vaxxers deny because the borders were closed and you had no immigration, was that the people who are currently dying immigrated here in the late 1950s. They were part of the £10 POM scheme, where there was a kids travel for free component to the family. So the number of 10 to 14-year-olds went up 44% in 7 years. And if you talk to someone in their 70s, the schools were being built around them as they went to school. And that age cohort has just started getting to the age where they are the principal drivers of death. Most people don't need that context for what was going on, but it's, you know, that's just an example of the context is there.
Grant?
I think your talk was a fascinating illustration, and was great, by the way, of that remark by Disraeli, that there's three kinds of lies: lies, damned lies, and statistics.
Yeah, I have certainly had that quoted at me on an occasion.
You've shown what subtlety you need to distinguish the statistics you ought to believe from the ones you oughtn't to believe in the way that they apparently are stated to you. And I think when we see Disraeli's remark in that context, it rings very true.
Yep. I mean, I wouldn't consider, and I realize this is just me as a data person, I wouldn't consider most of what I do in this sphere as statistics. There's very little modeling or anything else going on. This is just, you know, calculating averages, which, you know, I have written up 8-step guides to doing age standard mortality in Excel. You need 3 formulas and 3 blocks of data, and you kind of fill down and you're good. So putting on my public data advocate hat, it's that I'm a big proponent of people using data and using it well to inform them rather than being misinformed by others. And in fact, this is something that if I am in conversation with people who have been hearing stuff, is I do try and say, this is what you can do to check this, should you wish to. Sometimes resonates.
Ben's got his hand up. Could we unmute Ben, please? We can activate the video as well. That would be ideal.
I think, yep.
There we go.
Yep, you're good.
I've had a protracted conversation with a man who shares many of the views that you have disparaged. And one of the problems I found with my conversation with him is just that he doesn't have an understanding of maths. And he sent me a table out of a Scottish report once, which in one column had the death rates and another column had the total deaths. And the total deaths amongst the, I can't remember which way round it was, but basically he was drawing conclusions from the total death column, which were contrary to the conclusions of the death rate column, and didn't understand it. So I think there is a difficult problem. And I think the same problem in terms of the adverse event vaccine, adverse event reporting systems, which he regularly interpreted as meaning these are caused by vaccines. Not that this is an event that happened at the time following a vaccine and we need to investigate whether this could possibly be the vaccine, and the vast majority of them were not because of the vaccine. So I don't know what you do about that dilemma of providing data and then having people interpret it in ways because they've got no understanding of what they're interpreting.
Yeah, I absolutely agree and have seen similar cases of people unsuccessfully doing basic maths is, I think, the best way to describe it, that we would assume is basic. I think it is better to have data out there and have clear explanations of what and why is important, steps are done on the data. But you can't convince everyone to use those steps. But I personally would rather that most people in an informed, open democratic society, that most people had access to data to check for themselves and build confidence in institutions by being able to review what things were.
So on this matter, Monique has posted a question, and maybe we'll give Monique an opportunity to ask that loud. There we go. Thank you. I think that enables you to do this, Monique, if you unmute now, I believe. Seems to be what's happening.
Okay, so yeah, you're on the bus. To read out Monique's question, thanks for a great talk. What seems to change people's minds in your experience? I'm interested in how much it is to what is said or who says it that matters most. I try very, very much not to be who says it. I do not want to be seen as an authority. I want people to go and check, read to check what the correct maths is. I want people to consult the info share information themselves. I would like them to do that. That said, from my perspective as someone who operates in that way, the two things that make the most difference are combining the common sense with the maths, not just saying that it's more old people, but it's more old people because of the kids travel free £10 POM thing in the 1950s, aging up. And if you talk to someone in their 70s about going to school, about it is that combination of things they can check themselves and grounding it in everyday experience is very effective. And going back to that graph that I showed earlier, it is tremendously effective to just lay it out in one screen about what are deaths, what is the population, what is the death rates by age.
Thanks, David. I'm interested in this issue myself, and I don't know if Monique's thinking this too, but I'll ask it anyway. Do you know if any studies have been done as to what is most persuasive for a population as a whole? So one of the doctors I teach with likes to, I think it's the line is only 15% of people are persuaded by statistics. Do you know of any kind of robust studies of this sort of issue?
An extremely low number of people can read a scatter graph.
Right. That would be
far lower than I'm sure than most people in this room would think. I was actually reading something yesterday evening on anti-Nazi propaganda in the Second World War, and so this was the British campaign for winning hearts and minds, and the thing they were really finding was effective was empowering people, empowering them to be able to understand things for themselves, empowering people to be able to check things for themselves. How you do that in a cost-effective manner in this day and age is a whole nother ballgame, I think.
Thanks for that contribution there, Ben, to that point. I think there's another question in the room.
Yep.
Yes,
Ben.
I'll just spend a moment with this.
Yes, Ben made the good point in chat about for vaccine refusal, there is a strong correlation to adverse childhood experiences. I think you can see that in the Dunedin study from memory. And it's absolutely relationships of trust in those demographics.
Okay. Yeah, we might come back to those other comments. So there's a comment in the room. Mike?
A question. No worries if this is something that it's that you're not able to speak about, David, but I'm just thinking about the discussion we had earlier in the earlier in the year where, so it's fine if everyone's using publicly available information. So I know you've encountered situations where people have improperly or
Yes.
or
What do you do if
unethically-
someone steals several million patient records
Yeah,
and is making claims off the back of that?
yeah,
Which is a thing. There are a number of groups in the world. There is me as a public data person. There are public health people. There are anti-vaccination people. There are anti-vaccination people who are not necessarily public health people, but are really annoyed at anti-vaxxers. And if you steal several million patient records, anti-vaxxers will take a strong interest in what you do and don't feel constrained in the ways of not using the data that public health people do. So they do data level debunking on that. But when someone does steal several million patient records and makes a bunch of claims off it, you can also quite legitimately say, and you can demonstrate by making graphs from public data, that you don't need stolen patient data to make these misinformation claims. You can make just as many misinformation claims using public data, or misusing public data, I should say. And that is how I navigated the period. I could see the results of what was being claimed, being circulated. I absolutely refused to touch the stolen patient data myself, but I knew enough about what was being claimed that I knew what public sources were available to debunk it in various ways. But quite frankly, with the divisions in the anti-vaxxer community, there are people who are completely and totally against vaccination who have done debunkings of the claims made from the stolen New Zealand data. So what we see here is just one facet of what's going on in lots of places.
We might just scroll up just a little because thanks, Angela, and we're coming towards the end of our session, so we won't have time to cover all these points. So Janine shared something from New York, the New York Times.
Yeah, what is a COVID death? And in the very initial stages of the pandemic, COVID deaths were defined as deaths after COVID, as a way of measuring something. Much later on, it was defined by medical examination. And then it was retrospectively applied to older cases, which is why there's various jumps in the New Zealand death series depending on source and updates over time. And yes, this is a thing that anti-vaxxers say they're fiddling the numbers. But whatever you do, people, that is an audience that will complain about whatever gets done. It does, however, mean if you're basing it off medical examination, which is ultimately the best measure, is that there is a delay. So in New Zealand, the deaths that are announced on still announced on a weekly basis, those ones tend to be 4 to 6 weeks old. Whereas there's another category called under consideration, which is the very current ones. That's a subtlety and nuance thing, and I had no answers to.
Thank you. My next, I think this is probably quite a big question, but maybe there's a short answer for us to be going on with. What can we learn from how the misinformers gain uptake?
People like stories, people like people to blame. The classic fascist model of gaining power is to say, these people are an existential threat. I am fighting them on your behalf. And certainly there is a category of threat that gets directed at me that fits very much in that model. We don't want to start labeling people as threats, but it is, in my opinion, fine and ethical to provide context and stories and narrative around things that fits things together to make it more understandable and to ground things in people's own personal experience, to try as much as possible to link it to their own lives and what they have seen and witnessed and things like that.
Thank you. And lastly, from Sarah Jane, comments about ways in which complex information can be communicated more effectively to those less math literate. Yeah.
Yep. Just for, I'm sharing my screen yet again, having seen Sarah's question. And I've got my folder of quick images to hand. Historical newspapers can be a great source of graphics. So this New Zealand had the same scheme basically, but you can see children travel free, and if that gets doubled up, sadly New Zealand only has OCR versions, but I've got Australia just for 1954 and 61 as a historical scan, and the 10 to 14-year-olds go from 350,000, go from 694,000 to 1 million and some in that time period. Just showing it to people and explaining this was the late 50s, just add enough years on and these people are now here and dying. So, yeah, not that everyone needs a trove of, 3 years of COVID graphs.
Yeah. Okay, well, I think we should end the session now. I'm sure David would be happy to stick around a little bit longer. Actually,
Yep.
to check. Yes, he is. That's good. But let's thank him one more time. Thanks, everyone who joined us on Zoom. We'll see you next week.
Thank you.